Good afternoon, everybody. Thank you all for coming. It's my really true pleasure to introduce Shari Damats today. Shari is a world's expert on treatment of gynecologic malignancies. And you know, I'm not just throwing those words around. She really is a leader. And we're so lucky to have her here at Yale University. Shari trained at Cornell and then did her residency at Memorial Sloan Kettering and joined us 11 years ago. She's now professor of therapeutic radiology, and she built our HDR brachytherapy service here at Yale. Which is really an incredible accomplishment. So today she's going to be speaking to us about advances in treatment of cervical cancer. And welcome, Shari.
Thank you so much, Joe, for that very kind introduction, and it's really an honor to be here. So as you heard, I direct the gynecologic radiotherapy program here at Yale, and today I'm going to be talking about brachytherapy and the treatment of cervical cancer, how we approach these patients, and specifically the supportive and innovative programs that we have here at Yale for this unique patient population. And I have no financial disclosures. So cervical cancer is a global health problem. Worldwide, there's more than 600,000 new cases per year and more than 340,000 deaths in 2020. And it's particularly a problem in resource-limited countries where it's a very common type of cancer and a very common cause of cancer mortality. And in certain regions of Africa and Central America, it's actually the leading cause of cancer-related mortality. And unfortunately, this is a cancer that disproportionately affects women in low socioeconomic groups. And there are complex challenges for these women at every step in the cervical cancer continuum. In the United States, there's more than 14,000 new cases per year and more than 4,000 deaths expected in 2022. The highest incidence is among U.S. Hispanic, Black, and Native American populations. This is a cancer of young women. It is most frequently diagnosed in women ages 35 to 44. And as we all know, HPV is central to the development of cervical cancer. It causes more than 95% of cases. Risk factors include various sexual behaviors, including young age at first coitus, multiple sexual partners, history of STIs. It's also more common among those with a compromised immune system. So fortunately, screening, cervical cytology, and HPV testing has led to reductions in cervical cancer mortality, particularly in resource-rich settings. And the incidence of cervical cancer is affected both by epidemiologic risk factors as well as by having access to screening programs. So for those who are screened, cervical cancer may be discovered asymptomatically in very early stages, for example, because of an abnormal pap smear, or if a visible lesion is discovered incidentally on a pelvic examination. But these are not the patients that I see in my practice. So the types of patients that I might see in my practice are typically, let's say, a young woman in her 30s or 40s who has a very advanced cancer that's highly symptomatic. And she's probably had bleeding and pain going on for some time. She's perhaps bounced around between different emergency departments and different hospitals, misdiagnosed with fibroids or infection. And she's often from an underserved community. She is often suspicious of the medical system and has not had routine screening. She may even be suspicious of a GYN exam, perhaps a history of abuse or trauma in her past, and often life hasn't treated her well, and now she's hit with this. What do I mean by this? So this is locally advanced cervical cancer. That's when the tumor has grown to be clinically visible more than 4 centimeters. It invades beyond the cervix into the parametrial tissues. It can extend out to the pelvic sidewall, down into the vagina, can also extend into the surrounding structures of the pelvis, including the bladder or the rectum. And for these patients, the primary treatment is not surgery, but rather these patients are treated with chemoradiation and brachytherapy. The paradigm for treatment is shown here. And what I'm showing on the horizontal line is the time frame of treatment. So we try to get all of the treatments done within 8 weeks. So for the first 5 to 6 weeks of treatment, the treatment consists of external beam radiation, which is what I'm going to show you. These arrows connote weekly cisplatin chemotherapy, which has been shown in randomized trials to improve the overall survival in this population. So the first 5 to 6 weeks are chemoradiation. That is followed by brachytherapy, which I'm going to talk about today. And again, all of these treatments we try to complete within 8 weeks. Studies have shown that extending treatment beyond 8 weeks is associated with a reduction in tumor control and worse outcomes. I think many of you here are familiar with external beam radiation, also called EBRT. The patient comes every day to our department for 5 days a week for 5 weeks. She lies on a table that looks like this. This is called a linear accelerator that delivers high energy X-rays from the outside into a very carefully designed target like what you see here. And this is a target that's designed to incorporate the pelvic tissues that are involved, any lymph nodes that are involved in the pelvis, as well as the periaortic region, which is a common area that's involved with cervical cancer. And specifically with IMRT, like in the plan that's shown here, we're able to deliver a very carefully designed field to the areas that are at risk and give much lower dose to any of the surrounding structures in the pelvis through a very carefully modulated beam. Again, we're avoiding the bowel, the spine, the kidneys, the bone and the muscle. So we're able to deliver this type of treatment with much less toxicity than in the olden days. Another advantage of IMRT using the modulated beams is we're able to deliver a high dose to the pelvic lymph node regions and deliver a dose of approximately 60 gray while giving simultaneously a much lower dose to any of the surrounding tissues in the pelvis. But for cervical cancer, what's unique is that external beam radiation alone is not enough. The second half of their treatment is delivered with brachytherapy, also called internal radiation, where we have to deliver a much higher dose to the central tumor, really a dose of about 90 gray. And really the only way to do this is from inside the tumor, not from outside. So brachytherapy involves placing a radioactive source in direct contact with the tumor to kill the rapidly divided cancer cells that are surrounding it. In cervical cancer, this is done by placing a rod inside the uterus and a ring-type structure in the vagina. And through these applicators, whether they're plastic or metal, we're going to deliver a radioactive source that's going to dwell in these applicators and therefore deliver a much higher dose to the tumor. And in doing so, with a very steep dose gradient, going to give a much lower dose to any of these surrounding tissues. So unlike other types of cancers where brachytherapy is seen as an option, but there are other similar efficacious options like SBRT and protons, in cervical cancer, that's not the case. There's no substitute for brachytherapy because these other modalities don't allow us to achieve that very high steep dose gradient that I mentioned. But the thing about brachytherapy, it's different than external beam. It's interventional and it requires technical skill, but also specialized resources, different equipment, special applicators, and so not everywhere has it. This is a study from 2013 from the SEER database, which looked at cervical cancer patients with locally advanced disease who were treated with brachytherapy compared to those that did not receive brachytherapy. And you can see that the cause-specific survival as well as the overall survival is significantly improved among those that had brachytherapy. This is a similar study from the NCDB in 2014, again, more than 7,000 locally advanced cervical cancer patients, and specifically asked the question, how do patients who receive a different form of treatment to escalate dose to the cervix, such as SBRT or IMRT, compared to those who have brachytherapy? And again, you can see that the women that have brachytherapy have a significantly improved overall survival. So here at Yale, I'm very proud to work with a dedicated team who assure highly coordinated and interdisciplinary care for these women. These pictures are just an illustration of some of the people who might help with any of these cases on a given day. So we work very closely with nurses in the OR, in the PACU. We work with the technologists in the MRI suite. Within our own department, we have dedicated dosimetrists. We have radiation therapists who are intimately involved in our cases, dedicated nursing staff, physics, and we have faculty within our own department as well as faculty within the GYN oncology department that we work very closely with for all of these cases. We work with coordinators, administrative assistants, nurses, residents, fellows from all of these different departments listed here. These folks are not only committed to delivering high quality brachytherapy with safety and excellence, but what stands out to me is the compassion that they show in caring for the whole patient and understanding that this is a unique population, a treatment that can be painful, upsetting, or even traumatic for patients and requires a recognition of that as well as an interpersonal touch. The good news that I'm going to share with you today is that there has been tremendous technological advances in the field of brachytherapy over the past 10 to 15 years. And I am grateful for the support of my department, the hospital, and the Cancer Center for recognizing the benefits that these provide. Today, what I'll be talking about is how brachytherapy evolved to modern MRI-guided adaptive technique. I'm going to discuss the role of 3D printing in innovation and directions for future. I'm going to discuss training the next generation of brachytherapy providers with simulation-based education. And finally, I'll discuss the resources that we have here at Yale to help assure that these women go on to live normal lives after cancer treatment, given the challenges and potential morbidities, sexual and otherwise, that can be associated with such treatments. So how did we get here? So one of the things that drew me to the field of radiotherapy was the technological advancements. And while that's for sure true and well known within our external beam treatments and IMRT, it hasn't always been the case with brachytherapy. So there was a period of about 4 or 5 decades, I would say, between the 1960s and early 2000s, where brachytherapy really looked like this. It was kind of the same. This is called an intrauterine tandem that was placed inside the uterus, inside the operating room. And this is called a vaginal ovoid. And 2 of these would be placed on either side of the cervix. Again, we would do this under anesthesia while the patient was in the operating room to surround. These are metal applicators that would surround the cervix. They would get packed into place. And we would take an image of these applicators. Through these applicators, we would then load cesium sources to give off a cloud of radiation. So cesium sources came in different strengths, and our physicists would figure out how much cesium and where inside these applicators to place them to create a symmetrical pear-shaped distribution that looks like this. So we had mathematical formulas and lots of decades of data to know what type of dose we needed to get to these different points in relation to the applicators to achieve good outcomes, local control of about 75%. In the mid-2000s, things began improving in the planning, optimization, and treatment delivery. We had newer applicators that were compatible with an HDR source. So basically the applicators, they were kind of the same idea, a tandem. This is called a ring, which sits in the vagina. But after placing it, packing it, designing a radiation plan, rather than having a patient have to stay in the hospital. So with cesium, the patients would be admitted. In order to give off the dose cloud that was necessary, the patient would have to be admitted to the hospital for 48 to 72 hours with a decaying radioactive source inside of them. The benefit of an HDR source, which is iridium, is that the same treatment can be delivered in a course of about 10 minutes, and it can be done in an outpatient setting in a brachytherapy suite. So we could place the applicators, design the radiation plan, and treat them in a brachytherapy suite over a period of about 10 minutes. Once the treatment was done, they could go home. Another benefit of the applicators is that rather than just imaging them with a plain film, they were CT compatible. So that allowed us to not only see the applicators, but actually see the nearby organs, the rectum, the sigmoid, the bladder, the bowel. And we were still aiming for that symmetrical pear-shaped distribution, but we were able to optimize the dwell times and sort of shrink the dose cloud a little bit off of the surrounding organs and therefore give much lower dose to the surrounding organs. And it turns out that had a big benefit. This was shown in the STIC trial, which was a prospective but not randomized trial of about 800 women with locally advanced cervical cancer, and basically compared those that had the film-based treatments to those that had CAT scan-based treatments, so 3-dimensional, seeing the organs. And you can see that local control in both groups was very good, about 75%, like I mentioned. But the main advantage of switching to three-dimensional imaging was there was a significant decrease in grade 3 to 4 toxicity. So in the film-based era, the likelihood of having, bowel obstruction, perforation, bleeding, fistula was about 20 to 25%. Whereas once you see your organs and you optimize your beam accordingly, now the likelihood of grade 3 or 4 toxicity is only 2 to 3%. So that was a big advantage. The next advancement came in the mid-2010s, really pioneered in Europe by a group of researchers known as the Embrace Trialists. And what they sought to do is to incorporate MRI to improve the way we do brachytherapy and to improve local control. And really, this group created a renaissance in the cervical brachytherapy community by incorporating MRI into treatment planning. So MRI has always been an important diagnostic imaging modality for cervical cancer. We always get an MRI up front at the time of staging to help determine the local extent of the tumor, if there's any involvement of the vagina, the uterus, the perimetrium, the surrounding structures. And even in the LDR era, we would often get a pre-brachytherapy MRI after about 5 weeks of radiation. This is a rapidly growing tumor, so it responds rapidly to radiation. It can shrink by about 1 centimeter per week. So getting an MRI before brachytherapy would give us information about, how much of the tumor is left and also the dimensions of the uterus prior to going to the operating room. But the Embrace trialists took it one step further and said we could design applicators that are MRI compatible. We can do the procedure like we've done, place the applicators, but now instead of going to CAT scan, we can go to MRI, and now we can actually see the cervix in relation to the applicator and see the tumor in relation to the applicator and change the way that we prescribe radiation, different from how we've done it for decades. So I mentioned for decades, we were looking for this type of pear-shaped distribution, aiming to get radiation to a certain point from the applicators. But with this new way, they designed very carefully thought out and developed principles to allow us to deliver dose to the residual cervix and the remaining tumor as seen on MRI. So lots of institutions began adopting this approach, and they presented their retrospective outcomes. And you can see here that there was significant improvement in local control. When you look at these individual institutional studies, looking like local control was now about 90% or higher. So this looked really good and still very low toxicity. The EMBRACE trialists went on to develop a series of prospective studies following over 1,000 women and collecting patient-reported outcomes and validated toxicity information, looking not only how to optimize the way that we prescribe the dose to the tumor, but also seeking to reduce any treatment-related morbidity and how to optimally constrain the dose to the normal tissues. And they put out very high impact papers showing us how we could monitor the dose to the rectum to keep the rectal morbidity low. And similarly for the bladder, how to decrease dose to the bladder and keep the bladder morbidity low. And they even put out data for how to limit dose to the vagina to produce less vaginal toxicity for these patients. So with all of this mounting evidence, here at Yale, we were able to establish an MRI-based program in around 2016 or 2017. And in order to have an MRI-based program, you need to have access to an MRI. So some radiation departments have an MRI simulator in their department. We do not. So like others, we partner with the MRI that's available in our diagnostic imaging suite. You need to invest in MRI safe applicators. You need to meet with our radiology colleagues to develop proper sequences and protocols for imaging. And you have to study the concepts, these new concepts from the GAC-Gastro and EMBRACE, how to do this target volume delineation. You have to invest in an MRI safe transport system because you're placing applicators in the operating room and now you're taking them to the MRI. You have to have trained staff and you have to have integrated MRI safety procedures, patient questionnaires, and procedural checklists. So all of this has been our standard way for treating cervical cancer patients for the past 6 or 7 years. And this is what a modern MRI intracavitary tandem and ring plan might look like. You can see that the dose is very concentrated on the cervical tissue due to the physical proximity of the source to the tumor. There's a very steep dose gradient, so none of this high dose is going to any of these surrounding organs. This looks a little bit different than the old-fashioned film and point-based plans that I showed you, but I will mention here that because of the sort of simplicity of the applicators, this tandem and ring, you still have a symmetric dose distribution. But the more you start visualizing your tumors on MRI, the more you realize that not every tumor is symmetric, and also not every tumor is going to be perfectly covered by one of these symmetric dose distributions. So depicted here in blue is a tumor, and in red is the 100% dose that I'm trying to give. And you can see that there are aspects of this tumor in blue that are extending outside of the red. So that is with sort of pushing our dose the best that we can with our intracavitary applicator, whereas an ideal coverage depiction might look like this, where the entire tumor is covered in the red. So it turns out that if you take your standard intracavitary applicator, tandem and ring, and you add what are called interstitial needles that look like this, thin plastic needles, if you add a couple of these needles into the tumor, to the parts of the tumor that are extending beyond the boundaries of what you would expect to be covered with a standard intracavitary plan, then you could significantly improve the dose coverage. And this is the birth of the so-called hybrid approach, which is basically that it's saying that for tumors which are larger and might not be well covered with an intracavitary plan, you can add a couple of needles and thereby improve the dose coverage. And more places started doing this. And in fact, vendors came up with hybrid applicators that look like this. So again, like a tandem and ring, but within the ring applicator, there are holes that allow you to thread interstitial needles. So an example of the benefit of this approach is illustrated here. This was a young woman with a very large cervical tumor, stage 3B, invading into the left pelvic sidewall. She had a very large tumor that responded well to external beam radiation, but she still had a significant amount of tumor that was present at the time of brachytherapy. If she were to be treated with intracavitary alone, you would have this circular symmetric dose distribution around the tandem. What you can see here is this is covering the anterior aspect of her tumor, but she still has tumor which is sitting laterally and posterior to this dose distribution. So what you could do, and probably what you should do, would be increase the amount of radiation you're putting in the tandem to better cover the tumor target. Here you can see now we're covering that lateral and posterior aspect of the tumor, but because of the nature of these intracavitary applicators, you're simultaneously increasing dose anteriorly to the bladder. And that's going to result in an increased risk of bladder morbidity. So the benefit of these hybrid applicators is that rather in a case like this, you could thread needles into the lateral and posterior aspect of her tumor, which is what we did. And then you can shape the dose distribution more like this, pull that dose posteriorly to cover the target, and actually simultaneously reduce the dose going to the bladder and pull the dose back to create this asymmetric target. So what this graph shows is something that I think a lot of departments have seen, but once you introduce MRI, you suddenly go from a department where you're doing almost no interstitial procedures to very quickly finding that about 50% of your cases are being done with interstitial needles. So I think these days, customizing dose distributions on a per patient basis, we are doing this more and more. We're no longer aiming for that perfect pear-shaped dosimetry that I showed you earlier and that we did for so many decades. And maybe this seems simple to those of you in the audience, right? We're adding needles, more degrees of freedom. And yet the truth is there's a very steep learning curve within the brachytherapy community, and it does take time for these new concepts to catch on. And that might be because by training and by nature, many of us in radiation oncology are not interventionalists, but also sometimes there's inertia in changing the way that you've done things for decades. And also there's training and resources that are required to invest in these types of new procedures. So how common are MRI and interstitial? So this is an American Brachytherapy Practice Survey from 2014. So it's a little bit older, but it showed that between 2007 and 2014, MRI use increased to about 34% of practices. So probably nowadays that would be more. And a 2020 Canadian practice survey found that between 2015 and 2020, interstitial use increased, that's the use of needles, increased to about 70% of practices. So more and more places are doing this, but not everywhere. And currently we are the only place in Connecticut that does MRI-guided interstitial brachytherapy. So we do see a lot of referrals from around the state. This is an example of a 73-year-old who had a stage 3A cervical cancer with vaginal involvement. So she was treated with pelvic radiation at an outside hospital, but because of the extent of her vaginal involvement, she was not going to be properly treated with intracavitary radiation. And so she was sent here for her needle placement, which you can see here, in order to better cover this vaginal extent of her disease. This is a 41-year-old from an outside hospital who had a very large stage 4A cervical cancer. It was invading into local organs in the pelvis, but was also extending very laterally. So you can see here what her dose distribution looked like. If she were treated with just tandem and ovoids, her dose distribution would be more narrow. So we added needles to extend her dose out laterally to the side walls of the pelvis. This was a woman who had a very bulky cervical tumor that had a lot of bulk and also intrauterine extent at the time of brachytherapy. So she benefited from this Vienna applicator for dose escalation to her tumor. And this is a young woman that had had a prior early stage cervical cancer treated with a hysterectomy and developed a vaginal recurrence, mainly on the left side of her vagina. She would not have benefited from a symmetric dose distribution, but rather she needed needles, preferentially in the left fornix of her vagina, in order to give the proper dose. So as we use more needles, we realize that with MRI, it's helpful not just to sort of place everything in the operating room and then go to MRI post facto and what you get is what you get, but rather to use the MRI, especially for complicated cases, to actually help guide the needles. So we do that with iterative T2 sequences. So we'll bring the patient while they're under anesthesia to the MRI, place our needles the best we can. And if we need to make adjustments, we'll advance further, deeper into the pelvis, take another T2 sequence until we're happy with the needle adjustments. So this is kind of more of an MRI guided approach. And in addition to everything that I told you you needed for an MRI based program, here you also need to have access to an to an anesthesia team available at the MRI, which we are lucky to have here. We need to request extra time in the MRI suite because we're going to be taking multiple scans. We need time to make adjustments. And this also requires another level of care coordination between the OR, anesthesia, imaging, PACU, GYN oncology, et cetera. We reserve these for our most complex cases. So that is our current state of MRI at this time. And I'll just mention here, in terms of some research, there's research ongoing at Johns Hopkins led by Dr. Akila Viswanathan to try to improve the efficiency of the MRI procedure by developing kind of MRI tracking devices that allow you to see the needles as they're placing them in real time. So who knows, maybe this will be the state of the field soon. So all of this time and effort and attention to detail, is it worth it? So the data shown here would say that it is, especially for the larger tumor targets. The larger that your tumor is, the more important getting that proper dose is in order to achieve local control. So basically, covering your tumor better is directly correlated with controlling your tumor better. And another advantage by doing these asymmetric dose distributions and pulling the dose off of the surrounding tissues is you're giving a lower dose to the surrounding organs and causing less morbidity. And now all of this has been shown prospectively in the Embrace-1 trial, which was published last year in Lancet Oncology, which was the first large-scale prospective study testing all these concepts of MRI-guided brachytherapy. It accrued patients from 24 centers in Europe, Asia, and North America, more than 1,400 patients between 2008 and 2015, and results were reported at a median follow-up of 51 months. The main finding was that 5-year local control was excellent, 92%. What was especially impressive about these results is that this 92% local control was not just in the stage 1 and 2 smaller tumors, but was true across the board. Even in the stage 3 and 4 tumors, these very large and infiltrative tumors still had excellent local control, especially when we think back to the 75% that we sort of assumed in the olden days. They looked at overall survival at 5 years, which was 74%. There's no direct comparison, but by looking back at traditional cohorts, that's an improvement by almost 7 to 10%. There was significant reduction in dose to the surrounding organs, 50% decrease in major morbidities, and 5-year incidence of a grade 3 or higher toxicity on a per organ basis was about 3 to 9%. So these are all very positive outcomes for our patients. So what comes next? So I mentioned that for decades, it seemed like the field of brachytherapy was a little bit sleepy and there wasn't much room for change. And yet here we are now in 2023. And I feel like the way we do brachytherapy is ever improving. It's getting more customized. And I think the future looks bright. And part of that is because of 3D printing. As I've shown you, every patient and every tumor is a little bit different. And brachytherapy lets us get up close and personal. So the better that you do this on a per patient basis, the better her outcomes will be. But unfortunately, the regulatory system and industry are not always catching up fast enough. And although I showed you some of the modern equipment that we have available, it can take almost a decade for a new device to come to market and to be FDA approved. And it's not particularly profitable for the device companies because at the end of the day, it's just a small group of us specialized users who are doing these treatments. So a lot of the technological advancements nowadays is grassroots and ground up and led by the doctors. And maybe this is fortunate because it's forcing the people who know the field the best to innovate. So we're seeing a rising interest in 3D printing for brachytherapy because it allows customization, low cost, and convenience. So this was one of the first published examples of a 3D printed customized ring applicator to guide flexible needles into a complex target. So you can see this is a cervical cancer, which is extending to the sidewall and also to the vagina. Looking at this case up front, you kind of know this case is going to need at least 10 needles or so to properly cover it. So one way is to go to the operating room and freely place these needles and hope that your needles don't deflect and that they are going to penetrate deep enough into your tissue and land in the exact right spot. But what this group did is they said, well, based on her pre-brachytherapy MRI, we could design this custom ring cap that's going to go over the existing ring. And they drilled holes at pre-specified distance and at angles to help guide the needles into the right place so that going into the procedure, the brachytherapist was able to place these needles at the sort of predetermined spots and better shape the needles and guide them to the tumor. So, I think that there's now been a couple more of these types of published examples in the literature, and it seems like brachytherapy might be a perfect match for 3D printing given the individualization needed for every application. We're no longer in a one-size-fits-all era. This is another example of a 3D printed cylinder similarly to guide needles into a paravaginal location. And I will say that when you're in the OR in this very tight space and a very narrow vagina, and you're trying to properly, deflect and guide needles at a specific angle, it can be very challenging to do. So having an applicator, which is kind of doing that for you, it's bending and also stabilizing the needle in the right spot makes a lot of sense. This is work from a colleague of mine at Stanford University who worked together with her physicists and engineers at Stanford, that they came up with these templates. And they basically said, rather than 3D customized printing on a per patient basis, rather they developed a repertoire of templates to have in their department to use for all of their cervical cancer cases. So basically they designed a couple of 3D printed templates, and they choose one of these prior to a procedure. It hitches onto the tandem. So they'll place a tandem and their ovoids, and then through one of these templates, guide the needles into place. And they'll figure out ahead of time which template would be best suited for a given patient. They found this to be a low cost solution. It costs about $5 to print this in-house and $100 if they send it out to a manufacturer. It removes some of the variability and randomness of the freehand approach, and it helps standardize the procedure more. And that way it can make it more accessible to trainees or other practitioners who are looking to get started with a hybrid application process. This was a 3D printed applicator from two of our own brachytherapy physicists, Dr. Chris Chen and Dr. Jay Chen. So this was printed for a patient who had a very narrow vaginal anatomy that wouldn't fit one of our standard applicators and required needles. So 3D printing can be used to rapidly manufacture and implement customized vaginal applicators that could be sterilized, made of biocompatible material, and potentially result in high quality brachytherapy for patients whose anatomy is not ideally suited for commercially available applicators. And sometimes we need smaller ones or different shaped ones. This is a different 3D printed vaginal applicator that we're currently testing in a clinical trial here at Yale. It's not for cervical cancer, but for endometrial cancer, where vaginal brachytherapy is typically done after a hysterectomy. So just to orient you, this is looking at a patient sideways. This is the bladder, this is the rectum, and a typical applicator is this straight vaginal applicator. And through that, we aim to give a dose of radiation to the vaginal apex. So what this trial is looking at is asking whether, if we designed the applicator to look the same at the top where we're giving the radiation, but to taper and narrow as it exits the patient through the lower portion of the vagina and the introitus, if that would be more comfortable for patients and more well tolerated. So I mentioned the applicator here because of the story which led to its development. As a clinician, I had been walking around with this idea in the back of my head for several years. And then one day, completely by chance, I received an email from one of my colleagues who was working with a medical student who had a background and interest in 3D printing and engineering. And he just needed a clinical application. So the two of us met and we put our heads together and we designed and 3D printed this one, which I mentioned we're currently testing in a trial. So I think we're still very early on in this journey of 3D printing, but I do know that 3D printing is used in some of the other surgical fields, and perhaps there are others here at the Cancer Center or the medical school who have similar programs in development and would like to collaborate with us. As it stands now, I think potential applications of 3D printing for cervical cancer brachytherapy include manufacturing personalized guidance templates to optimize needle positions and target dose distributions, also designing individualized applicators to fit patient anatomy. And I do see this as an area of future growth and promise. So now I'm going to talk about efforts to improve the way that we teach brachytherapy to our trainees. So I mentioned in the beginning of my talk that without brachytherapy, survival outcomes in cervical cancer are not as good. And yet, the same research has shown a disturbing high recent decline in the utilization of brachytherapy. So specifically between 1998 and 2009, it was estimated there was a decreased utilization rate of brachytherapy from 83% to 58%. And also the research has shown that patients are less likely to receive standard of care treatments at low volume centers. There has been a lot of thought and writing about this particular problem and the potential causes for underutilization of brachytherapy. It could be because of a lack of equipment, because of the intensive workflow. If you're at a smaller practice, you're treating all types of cancers, maybe you don't have the time and resources for this type of a cervical cancer program. There's also patient access issues. Not everyone can travel for these treatments. And something that's also come out of numerous surveys is perhaps we aren't properly training our residents. And there was a survey of recent grads and trainees who felt that not seeing a lot of cases during their residency training was a very big barrier to learning brachytherapy. So perhaps people were coming out of training and not feeling comfortable or confident that they could do brachytherapy. So as a field, we've realized that we need to improve the way that we teach it to make it more accessible and to change its perception from being an advanced, technically challenging technique to one that's a component of routine practice. So it's hard to teach brachytherapy in real-time cases. The stakes are high, the patient's under anesthesia, things are moving pretty quickly. So to supplement training, there's been a growing interest in doing simulation-based education, which basically means using a pelvic mannequin in a setting outside of the OR where you can conduct workshops with residents and they can have the opportunity to place the applicators in a low-risk setting. And this has been shown to help trainees remember the steps of the procedure and feel confident in doing the procedure so that they're more likely to do it when they go out in their own practice. And I've been able to participate in these workshops at an institutional level, also at national and international meetings. And this picture is taken from work that I did during my sabbatical in Israel. So I also mentioned earlier in my talk the movement towards more customized applications using needles into the residual cervical tumor. For a long time, the mannequins that were available to us were a very kind of hard, durable plastic material that wasn't very stretchy and didn't really permit needle placements. But in 2021, a new prototype Phantom was released. This model was made of this colloidal material that it was stretchy. It had a vagina, cervix, uterus, rectum, and bladder, and it also permitted our applicators as well as needle placements. So we designed an inaugural workshop here at Yale to validate the model for teaching hybrid needle placements. We presented this work at ABS, the American Brachytherapy Society, last year, and recently published our results. This was from the 14 residents in our program who were surveyed, and this was their responses to questions pre and post workshop. We asked them questions about their knowledge, preparedness, confidence in performing hybrid brachytherapy procedures. Red meant that they were not at all confident. Blue meant that they were very confident. So you can see the shift in responses from pre-workshop to post-workshop. Obviously, we know you can't do this workshop one time and expect everyone to be experts, but there are there's lots of programs and developments at a national level to improve brachytherapy training, but at least at an institutional level, we hope to continue conducting similar hands-on workshops yearly in our program. So in the last few minutes, I'm going to shift gears and talk about quality of life and survivorship in cervical cancer. This is another area at Yale that we have a lot of support with help from our behavioral health and gynecologic colleagues to make sure that our patients are onboarded with this information. As I think I've shown, brachytherapy is a very personal treatment, and while going through it, it can be intense and emotional. For some women, it can even be traumatic, though we do our best to offer compassion and support every step of the way. Post-treatment, even if the cancer is cured and the patient wants to forget about it, put it behind them, the problem is that there can be significant long-term sequelae which take time to develop. These can be sexual or other effects that can negatively and permanently impact the lives of our patients if they're not properly addressed. But many of these issues can be addressed, treated, or even prevented, so we have to follow our patients very closely. So in my opinion, post-treatment care of women who've been through brachytherapy is a critical aspect of caring for the whole patient because we don't want to save one part of their lives and then accidentally ruin another part. So this is just an example of what happens to vaginal tissue after radiation. Now, we all know that whatever your treatment modality is, whether it's surgery, chemotherapy, or radiation, the name of the game is to minimize side effects. So here's what happens after radiation. This is a biopsy from a healthy, normal vagina. This is looking in the basal layer, and you can see this is elastin, which is imaged with autofluorescence, and it looks nice and linear. This is a biopsy from the vagina of a cervical cancer patient 3 to 5 years after radiation. So again, it takes time, but what you can see is proliferation and elastosis, and this can lead to progressive thickening and stiffening of the vagina. This can take months to years to develop after radiation, and its effects can be permanent, result in difficulty with exam or pain with intercourse. So vaginal morbidity to some extent, whether it's mucosal adhesions or bleeding after radiation, is pretty common. And even if it's mild, that can have a significant impact on sexual function. And the impact goes beyond the physical manifestations. Studies have shown that 1 to 4, 1 to 5 cervical cancer patients have vaginal issues causing dyspareunia, and a significant proportion of these women stay sexually active despite pain to maintain their partner's satisfaction and avoid marital problems. So this is a pretty complex problem. Physical symptoms can lead to all of these issues here, whether it's distress, fear of pain, cancer, loss of femininity, decreased body image, difficulty with partner communication. A very simplified example of this would be a young cervical cancer patient who's treated with radiation. She has pelvic issues that result in problems with dyspareunia. She doesn't bring it up with her doctors. She remains sexually active, albeit with tremendous pain and suffering. She has relationship issues that result. Her partner leaves her. She has low self-esteem and she thinks something's wrong with her. I'm not saying that we as radiation oncologists can help with all of those issues, but we could do a lot simply by raising and normalizing sexual concerns with our patients, asking them about what they're experiencing, and making appropriate referrals when needed. So one simple thing that we can do is really just ask our patients about their symptoms. So this is guidelines that were written by ASCO. So I'd encourage you all to take a look at this if you haven't seen it. It was put out in 2018, looking at interventions to address sexual problems in people with cancer. The number one recommendation is that it's the provider's responsibility to initiate this conversation and to ask patients about their symptoms. So how are we doing in radiation oncology? This is an abstract that was presented at ASTRO in 2022, looking at disparities in physician assessment of sexual dysfunction in women versus men receiving brachytherapy. The men population was prostate cancer, women population was cervical cancer. Among the prostate cancer patients, 90% had sexual function assessed. Among the cervical cancer patients, about 10%. So I think that unwittingly, a lot of providers aren't addressing sexual health with their patients, especially with their female patients. It's probably not on the provider's radar. It's not really part of our culture. I remember seeing this firsthand as a resident, understanding that patients are having these issues, but not really knowing how to address it, not being trained how to address it. So there's a lot of barriers to discussion. You can see here, there's physician barriers, there's barriers on the patient side as well. And when you add these up, it's becomes very difficult to talk about these issues in the clinic. And I think it's especially amplified in the female cancer population. But I think that one of the main reasons why doctors might not ask is because they might not know how to address the problems that they might uncover. But the tragedy of that really is that there's a lot of very, very simple, low-tech tools that can really be available to everyone. So these are strategies to improve vaginal and sexual health. And I would say they could be effective for probably about 80% of the types of symptoms that we see after radiation. So just some examples would be educating patients and giving them dilators to improve elasticity and prevent adhesions. A lot of our patients have atrophy after radiating the pelvis, the hypoestrogen, and also fragility of the mucosa as a result of the radiation, the brachytherapy. Vaginal estrogen is very helpful, improving soreness and friction, lots of education about lubricants and moisturizers, or improving, genitourinary symptoms of menopause or climacteric symptoms. A lot of our patients benefit from hormones. So in our practice, we recommend a comprehensive approach where the conversation starts before any treatment's been given. Up front, we counsel patients about potential vaginal and sexual morbidity, quote, incidence rates, discuss mitigation strategies, and normalize the concern. During the radiation planning, we try to limit the vaginal dose as much as we can. Now we have guidelines from the Embrace and others as to how to do this effectively. And then in terms of secondary prevention, a lot of the strategies that I showed you earlier, recommending dilators, lubricants, moisturizers, screening patients for sexual concerns, assessing vaginal and vulvar tissue quality, screening patients for menopausal symptoms, and referring our patients for further counseling and intervention if warranted. So I'll mention here that education on this topic is an interest of mine, and I am a board member for an organization called the Scientific Network on Female Sexual Health and Cancer. So for those of you who are interested, the website is shown here. It has a lot of links to valuable resources, both for patients as well as for providers. So I'd encourage you all to take a look. And back in November, I hosted here at Yale the 8th annual scientific meeting, which drew almost 100 researchers from around the country. We are very lucky at Yale to have the SIMS clinic. So we realize that physical symptoms aren't the full picture and that sexual dysfunction can be a complex problem that has psychological, relational, and cultural components. And the symptoms caused by radiation can compound already existing emotional and interpersonal issues. So one of this resource is the SIMS clinic, which was developed by Dr. Ratner and Dr. Minkin, and has representation from GYN oncology, gynecology with specialization in menopause, as well as psychiatry and psychology. And they do a comprehensive evaluation for our patients. We refer many of our patients there for their sexuality, menopausal, and intimacy needs after brachytherapy. So I'm making a major plug for this wonderful program. And actually at the meeting that we hosted here in November, it was a pleasure to have a presentation from the SIMS clinic. I should mention that's also run by Johanna Diodario. And it's really one of the oldest programs in the world like this and has served as a model for many of the others to emulate. So with that, I'll end. We should be proud at Yale to have the resources that we need to treat our cervical cancer patients the best way that we can, and to also help them live their lives the best way they can when treatment is done. So thank you for your attention, and I'd be happy to take any questions. Okay. Joe.
So great, fantastic talk, Shari. So the amount of personalization of therapy is unlike any other site that we treat with radiation oncology. And so I was curious just to hear a little bit more about how you work with the community, because obviously we have all of these resources here. We have you here, and you mentioned some of your patients get treated a little bit in the community and then come here. How do you negotiate that, and how do you work, I guess, with the outside referring doctor to get that done?
Yeah, I think that's a great question. So I don't see myself as like a technician. Like philosophically, I care for the whole patient. But I also want to say that the good news is there are brachytherapists in Connecticut. I'm not the only brachytherapist in Connecticut, and they do a wonderful job. So many patients are treated at outside hospitals, but they also know, our referring doctors know, that for patients that need a lot of needles, if it's a particularly big tumor or a vaginal that has a lot of vaginal involvement, they will send them up front to see me, and I'll partner with them so I don't think I need to be treating all of the cases in Connecticut, but there are some cases that will really clearly benefit from needles. In general, we don't want to split care between teams. So I think, if there's one doctor that can do the whole thing start to finish, that's going to be better. There will be less delays and you'll get through that treatment time a lot quicker. And, so I think that when there's really no other effective way, I'm always happy to see the patient. I meet them up front. And this is kind of our policy here. We always review their pathology here. We are part of the decision-making up front. We do our own baseline exam. And, because of resources and whatnot, I have to set up the OR times in advance. So I guess I see myself as a referral for the most complicated cases, but not for all the cases. Does that answer your question? Yes.
So for the MR-guided brachytherapy complicated sections, especially interstitial cases, you mentioned about it. You adjust the placement under the MR. So you place the under MR images or transcranial ultrasound?
Oh, that's a great question. So, right. So the question is about real-time image guidance of needles. So you're right. There are several, not a lot, but there are some institutions that have an expertise doing transrectal ultrasound, and that is a very good modality to see where you're placing your needles in real time. And others do MRI, kind of like how we've been doing it. I think there's also a, what do you call it, like a learning curve with the transrectal ultrasound. So I tried it a couple of times, but I found that sort of placing the needles and going to MRI was effective for me. But there are practices that do the transrectal ultrasound with excellent results. Yeah, that's a good question. Yes. Yeah, they can do it pretty quickly. I don't recall in that particular case, but I think it's faster. So I would like to grow our 3D printing program. I think that's really an area for future development and a lot of promise. So like I mentioned at Stanford, they have an in-house 3D printer within their own department, so they can do that very rapidly. I don't think it takes too much time to do, but we needed a couple of weeks to do it for sure. Yes. So I don't see Chris in the audience. I think he's done some research into that question. So the MR Linux, I think you can use to image I think it is the right, magnetism that you can image your implants well, but I don't, and I know one of our physicists has sort of looked into that, but because we don't have an MR Linux, so I haven't examine that too extensively, but I think that it would be compatible with the majority of the MRI safe applicators. Yes.
So looking forward to new innovations and new therapies, as you know, proton therapy coming to Yale. Do you think that that's another modality that you'll be able to use to reduce side effects? And are there currently other sites that are using proton therapy? Do you mind?
So it's not that common. I know that Dr. Lily Lin at MD Anderson has the most experience using protons for gynecologic malignancies, but apart from that, I don't think it's been used that often. I don't think it'll replace brachytherapy, but in terms of whether it would be useful for pelvic radiation, there's really not a lot of data about that at this point. I feel like when we start our program, we're going to be focused more on some of the more CNS type of and pediatric type of cases, but maybe with more research, we'll see if that's helpful. So to be determined, but probably for reirradiation cases, I can imagine that will be very helpful. Okay.